Good morning, everyone. It's my pleasure to get proceedings underway today. I'm going to be going over the results of the MSLT 1 and 2 trials, seminal trials, which are really practice-changing. But more importantly, I'm going to focus on the clinical implications for someone in practice following the publication of both of these. And essentially, at the end of this talk, my goal is to answer the last bullet point. How is the management of node-positive melanoma different now from perhaps when a lot of us trained? I'm going to start with a clinical case. So your patient is a 54-year-old male with a 1.3 millimeter melanoma of the left calf on shave biopsy, following a wide local excision with 1 centimeter margins and a sentinel lymph node biopsy. The pathology shows no residual melanoma and 1 out of 3 positive sentinel lymph nodes. Which of the following choices is true? The status of the sentinel lymph node does not correlate with prognosis. This patient will have improved melanoma-specific survival compared to a patient who did not undergo sentinel lymph node biopsy and has clinical disease on follow-up. Choice 3, there is improvement in melanoma-specific survival for all patients undergoing sentinel lymph node biopsy compared to observation. Number 4, sentinel lymph node biopsy has a high rate of false negatives. And number 5, this patient has a high risk of further metastases being present in non-sentinel lymph nodes. Okay, great. I will be addressing each one of these as we go along. So let's start with the MSLT 1 trial. This is the final and updated publication in 2014. The original one, the first results came out in 2006. MSLT was a very simple design. It was a randomized trial in which the patient population was anyone with an intermediate thickness primary melanoma. This was truly multi-center and international, and they recruited more than 1,600 patients and then randomized into 2 groups. The first one underwent standard management, wide local excision with sentinel lymph node biopsy. The other group underwent a wide local excision with observation, so no sentinel lymph node biopsy. And if these patients, while they were